I'd like to thank Dr. Walker for giving me the opportunity to be part of the NCBH digital series. My topic for today is transradial carotid intervention. Why, when, and how. I'm Dr. Anish James Thomas. I'm an interventional cardiologist and vascular and endovascular physician at the Mercy Clinic, Heart and Vascular at Mercy Hospital South. These are my disclosures, not particularly pertinent to this talk. When we talk about carotid artery stenting with embolic protection has been shown to be equivalent to carotid endarterectomy. While transfemoral approach remains the conventional access site for carotid artery stenting, alternate access sites include transradial, transbrachial, and more recently, TCAR. However, even direct carotid puncture has been performed. I'm going to start with a case. This is a 79-year-old male with risk factors of hypertension, dyslipidemia, prior CABG. He was recently admitted with a non-STEMI and noted to have decompensated heart failure. He was noted to have critical aortic stenosis and was being evaluated for transcatheter aortic valve replacement. His carotid duplex study, however, showed severely elevated velocities in the right internal carotid artery, critically elevated at 490 centimeters per second. He was referred for carotid artery angiography and carotid artery stenting prior to TAVR, given that he was thought to have an elevated risk of stroke with some atypical symptoms. This was his diagnostic angiogram that shows a type 3 aortic arch and a critical carotid stenosis. Using the transfemoral approach in certain complex arch anatomy remains one of the main reasons for technical failure, increased incidence of ipsilateral peri-procedure stroke, and also an increased incidence of contralateral stroke. When we talk about complex arch anatomy, we are basically referring to type 2 and type 3 aortic arches that have a common origin of the left common carotid artery or just a bovine type left carotid artery, which makes it extremely difficult to cannulate from the transfemoral approach. Talking about transradial carotid artery stenting, this has been described as early as the 1990s as a successful and a safe approach for patients with complex arch anatomy. Patel and his colleagues described using the contralateral radial approach for carotid artery stenting with high technical success and very low complication rates. Its use in complex arch anatomy potentially minimizes catheter manipulation in the aortic arch, therefore decreasing the incidence of stroke and contralateral stroke. When you talk about the transradial approach, if you compare it to the transfemoral approach in coronary interventions, we do know that there's a decreased incidence of vascular access site complications, a lower incidence of major bleeding, potentially a mortality benefit, definitely early ambulation and early discharge, and decreased length of stay. This was a randomized controlled trial comparing transradial and transfemoral approach for carotid artery stenting. This was a multi-center prospective trial enrolling about 260 patients deemed high risk for carotid endarterectomy. There was no difference in major adverse outcomes, no difference in procedure or fluoroscopy time. There was a higher crossover rate in the transradial arm. Radiation dose was slightly higher in the transradial arm, and hospitalization stay was decreased in the transradial arm. However, the incidence of MACE was very similar. When we talk about transradial carotid artery stenting, we talk about the steps of getting radial artery access, transradial carotid angiography, and getting the sheath and guide to the common carotid to deliver the equipment. When you talk about radial artery access, these patients should be sedated to decrease the incidence of radial artery spasm. We do use vasodilators like verapamil and nitroglycerin. However, in this patient with critical aortic stenosis, we had to be careful. I always recommend doing a radial angiogram, and trying to access the radial artery under ultrasound also helps, which gives you an idea about the overall caliber of the radial artery. Talking about carotid angiography, if you're trying to cannulate the left common carotid, usually reverse curve catheters like the Simmons 2 or Simmons 3 help. But however, if you have a bovine arch, just a JR4 diagnostic catheter will work just fine. When you're trying to cannulate the right, a Simmons 2 or Simmons 3 will help. However, you have to be careful that when you pull this back up, it can come in contact directly with the carotid bifurcation. So you have to be careful when you're doing this. Sometimes a JR4, an IM, or a rim catheter will work as well. When you talk about delivering the sheath or the guide, there are three basic techniques to do this. One is the telescoping or the coaxial technique, the anchoring technique, and the claret or the catheter looping and retrograde engagement technique. The coaxial technique or the telescoping technique involves getting your diagnostic catheter into the common carotid, using a supportive guide wire, and then telescoping your sheath over this. The anchoring technique essentially involves getting a stiff wire into the external carotid and then delivering your sheath over the stiff wire. The claret technique essentially uses almost a backdoor type of technique in which you use the right coronary, the cusp of the aorta, the right coronary cusp, and loop a wire on this, engage the carotid, and then deliver preferably a guide rather than a sheath over this. This works better from the left radial approach, and overall it's a less stable platform compared to the other two techniques. Coming back to our case, this case did have some radial spasm that was relieved with use of vasodilators. We were able to advance a 90 centimeter shuttle sheath up to the distal subclavian. We then engaged the right common carotid using a reverse curve catheter. This was a SIM2 catheter. We advanced the catheter over a soft wire we advanced the wire into the external carotid, and then as you pull the catheter back, you can actually control the delivery of the guide catheter up to the distal common carotid. Once you get this in place, the shuttle sheath is then telescoped over this wire as well as your diagnostic catheter. In cases like this, be careful when you're pulling a diagnostic catheter and wire back. Pull it gently and slowly as the guide sheath tends to back out a little bit. So holding a little forward tension on the sheath does tend to help. Once you have your sheath in place, the rest is extremely simple. This was a critical stenosis at the ostium of the internal carotid artery. We were able to deliver a filter stent with an extremely good result, and this patient had no complications. So in conclusion, transradial carotid artery stenting is an attractive alternate approach, especially in patients with extensive peripheral vascular disease, complex arch anatomy. Safety, success, and feasibility has been demonstrated. With experienced operators, the MACE rates are extremely low and comparable to transfemoral approach. There are, however, limitations. Sheath and guide sizes will dictate what equipment can be used. For the most part, you can't use proximal embolic protection. However, in Europe, where they have the 8 French MOMA system, transradial carotid artery stenting using the MOMA has been described. Thank you.